And get us started. So excited to see all of you. Welcome back if you've been with us before, or if this is your first time. Thank you for joining us so much. So I will go through and just make sure everybody's muted, but don't worry, there will be time and opportunity for you to put any questions that you might have in chat, or after Dr. Fair has completed his presentation, there will definitely be times for you to unmute yourself and ask questions. Today's call will be recorded, so there will always be that opportunity. If you want to go back to this presentation at a later date, you'll have that opportunity, as well as all of our previous presentations are recorded, so that gives you the opportunity to go back to them as well. Um, so we're so pleased today to have Dr. Thomas Fair join us. He is a PhD board certified clinical neuropsychologist and faculty member at the University of Idaho, where he serves as an associate program director in the School of Health and Medical Professions. His research focuses on dementia and risk and prevention. And just so excited to have you here with us, Dr. Fair, and I will turn it over to you.
Okay. All right. So I'm still coming through clearly.
Mm.
All right. So stop me at any point, Mary, if there's audio issues. I've found personally that sometimes my audio in Teams will come through a little funny. So, but thank you for the opportunity to present. I'm happy to see the number tick up a little bit at a time with more and more people entering. So, but I'll go ahead and jump in. So and I see Ablash on here and Sue Melchiori and a couple familiar names, and delighted to meet others as well. At the end of this presentation, I have my contact information. I like connecting with folks in the community about these topics, so happy to chat offline as well. So assuming PowerPoint's going to cooperate with me, I'll go ahead and advance through. And I'm going to minimize the video so I can see my entire screen. I assume you can still hear me though. Okay, so Abalash had mentioned a book. Yes, I did publish a book this last September called Reversible Causes of Cognitive Impairment and Dementia. And this presentation is partly based off that work, as well as some of the research that I do here at the University of Idaho. And I have to thank Dr. Lynn Schaefer. Dr. Schaefer is a neuropsychologist as well in New York. And she and I have collaborated on some research. This is actually our second book together. And it came out, I think, September or October of 25, somewhere in there. And we are in early conversations about a companion second book to this topic, because this book really focuses on health-related factors that can masquerade as cognitive impairment and are potentially treatable, which can have a positive impact to improve cognition. But there's a lot in the field about preventing dementia that this book does not cover. So we're thinking about a part two project right now. Of course, just as in interest of a disclosure, I do receive royalties related to this book. And of course, I'm going to be talking a lot about health-related factors, but this presentation doesn't constitute medical advice. And I encourage folks to chat with their primary care doctor if they have questions about these particular topics. So I'll jump in here. There we go. So if I had some goals that I would want for this presentation, it would be that everyone on the call would have a really strong foundational knowledge of the definition of dementia, how that's distinguished from mild cognitive impairment and normal aging. And then the main theme of the book that I published and the main theme of this presentation today is thinking through the difference between what we call primary causes and secondary factors. So I'll be talking a lot about that. So hopefully you have by the end of this talk, feel pretty good about that. I also am kind of hopeful that regardless of who you are, whether you are a caregiver or a medical professional or anyone, you may something may catch your eye in this presentation that relates to you personally, and you may find, oh, there's a way in which I can improve my own health to lower my risk of cognitive decline. And even if you already have a diagnosis or a loved one has a diagnosis of dementia or mild cognitive impairment, the goal is to, again, identify something where you can say, well, there's more I can do to lower my risk and improve my thinking skills. So I won't focus on this slide too much. The thing about the impact of dementia globally is we're expecting that the prevalence of dementia will triple in the next 25 to 30 years. And the reason that really stands out to me as an educator um, is this is exactly the time frame of people who are going through training right now. So if someone is going through training to be a nurse or a physician or a psychologist or gerontologist, the time frame of this global impact of dementia is your career time frame. So and so I think that's really important to think about. So I always tell trainees, unless you're going into pediatrics, a large portion of your patient population over time is going to be middle-aged and older adults. And so it behooves us to be aware of dementia and how to lower the risk of dementia. And then, of course, distinguishing this from normal aging is critical. It's important for reducing risk. It's important for early identification and triage. And it's also important for helping people just lower their anxiety because a lot of people fear dementia and cognitive change with age. And if they have, mild word finding difficulty at some point, they may say, "Oh no, I'm turning into my mother, or I'm turning into my grandmother who had dementia," and so we want to be able to just distinguish what's just kind of considered normal. So I like starting with this graph, and I apologize if the font is small, but on the vertical axis, you can see it says WB volume. And what that stands for is whole brain volume. So it's a measure of how large or how much tissue there is for your brain. And then on the horizontal axis, there is the age across lifespan from birth all the way through. They plotted what looks like close to 90 years of age. And I want to stress that this plot here is actually from data from normal, healthy people. So these are not individuals with dementia. This is people who have just normal, healthy aging. And you can see that brain volume actually declines or goes down with time. So we are all basically around age 40. I don't know, Mary, can you see the mouse moving on the screen just so I know if audience?
Yes.
Yes, okay. So beginning age 40, we actually all have a decline in our whole brain volume. And again, that's just normal aging. This next slide is going to look a bit overwhelming, but I promise I'm going to walk you through it. So keep this curve in mind that we do lose brain volume with age, even if we're healthy. This slide looks a bit overwhelming, but I want you to just kind of ignore the black dots and look at this kind of salmon color trajectory in the middle. What this is it's similar to this, where volume is going down with time, even among healthy brains. This is cognition. So this is thinking skills like memory and attention and executive function, like reasoning and problem solving and things of that nature. And they plotted around age 60 to around age 90 to 100. And again, this is among individuals who are cognitively healthy for their age. They do not have dementia. And so some degree of cognitive change is actually completely normal. It does not mean that there's a disease. It's just part of the aging process, and that's to be expected. So what we want to do, though, when we're thinking about the kind of work that Sue Melchiori and Abhilash Desai do, and as physicians and others on this call, and the kinds of things that I do as a clinical neuropsychologist, is we want to be able to capture early on anyone who's at risk and intervene, and then also identify where someone is relative to their healthy peers. So when we think about normal aging, we do expect that there are some natural things that will change. Sensory abilities like hearing and vision do have natural changes. We do know something we call processing speed, which is our reaction time. That does go down a bit as we age. So at 55, we're not going to have the same reaction time as we did when we were 25, and that's okay. We don't acquire new information as readily as we did when we were younger, and that's all right as well. It takes longer to retrieve common words. Word finding difficulty is very common after age 40, 45, to be in a conversation and say, what's that thing called? Or who was that actor's name? That's actually just kind of par for the course from midlife on. And so it doesn't necessarily mean there's a problem. It can also be harder to pay attention and and focus on more than one thing at a time. So more things divide our attention. So, when you're driving a car in a busy city, when you're 25, you got a conversation going on with your passenger and the radio's on, and you may find now that I'm 50, I have to turn the radio off because I cannot focus on more than one thing at a time. Telling your passengers be quiet while I figure this out, that kind of thing is actually pretty common too. And then episodic memory. So thinking, what did I eat last night? I don't remember. Was it Thursday or Friday that the Smiths are coming over? Things like that. Okay. So those are, again, those are normal things. So when we distinguish this from disease processes like dementia and mild cognitive impairment, the solid line that you see over here is pretty much what I was showing you with the brain change and normal changes with age. So that's going to happen with all of us, just normal aging. By definition, things like dementia and mild cognitive impairment would suggest a premature or more rapid decline in thinking skills like memory or other aspects of cognition. Okay. Early on in the course, in this kind of preclinical area, it can be difficult to distinguish, meaning someone feels as though there's changes going on, but it's difficult to really capture and know for sure. But as time goes by, if there is a disease that's developing, it can become more and more obvious with time, and that separation can be distinguished in clinical practice. Nowadays, especially over the last decade, there's been more and more research on being able to detect things earlier with blood biomarkers or spinal fluid biomarkers and imaging biomarkers to be able to see, can we identify people at risk even earlier so we can intervene? And so that research is improving with time. So the field of neuropsychology, if we're doing assessments on people to see if they have normal cognition or cognitive impairment that's more on the mild end or more pronounced, what we're trying to do is use this continuum that you see on the bottom, where we can say, well, okay, let's say I have a 65-year-old come in for an evaluation and they're performing on tests the same as any 65-year-old, any healthy 65-year-old. That's all right. We could do a little bit of a thought experiment and say, well, would they perform the same as they did when they were 40? Maybe not, but they shouldn't be performing the same as someone who's 85. We want them to be performing at comparable to their healthy peers. Okay. All right. And so what's going on kind of underneath the surface, many of you know this already, is that as a disease is going forward and as the disease progresses, what you're really seeing is that there's an accumulation of the pathology developing in the brain. So as there's more and more accumulation of the pathology, there's more and more symptoms. The brain is trying to be resilient, but it's hard to do that. And so with the more this disease builds up, the greater degree of change over time. And then from a diagnostic standpoint, when you hear the word dementia, there is a research definition of dementia. So it's a little bit different. A research definition is looking at things like imaging or biomarkers, and that's really helpful. But for the most part, we still think of dementia as a clinical diagnosis, which would really mean three things. And so these three things have to be checked to make a diagnosis of dementia. And the first is, you can see there, we have to have evidence of a cognitive decline, so changes in memory or other thinking skills. That represents an inter-individual change. And what we mean by that is, if someone has had a cognitive impairment their entire life, and now they're 65 and it's the same degree of impairment, that wouldn't really be the same as dementia. So it's a bit different. So this is a new change in thinking skills. and it has to be objective. So we have to measure it with testing. We also gather information from family members or loved ones to get a sense of how it's impacting their life. So that we have to check that first box. The second box is if we're going to diagnose dementia, that change has to have reached a threshold that it's now negatively impacting a person's functioning to some degree. So we think of this what we call activities of daily living. This can be complex things like driving, managing finances, managing medications, etc. But can also, especially later as the disease progresses, it can impact more basic things as well. And then part three is we have to rule out other things. So we have to make sure that what we're seeing in a clinical setting is not because of delirium or another psychiatric illness. And I won't really unpack delirium right now, but that's an acute change in thinking skills that's usually associated with health like electrolyte imbalance or infection or dehydration or head injury that causes more of an acute change. So we have to rule that out. So if we check all these boxes, that's when we would start to say, okay, this is a clinical diagnosis of dementia. Of course, dementia is an umbrella term, and there's a lot of conditions that we can put underneath that umbrella. The one that most people have heard of, we're talking about ADRD Alliance and Hope Conference and things of that nature. The most common one that people know is Alzheimer's disease. But there's others. A very common one is vascular dementia. And then you may have heard of Lewy body or frontal temporal dementia as well. These are actually the four most common forms of, uh, of dementia. At this time, there's no cure for dementia. There are other forms of dementia, but these four are the most common. And we can see that here as well, that when we think about the prevalence of these conditions, with dementia being the umbrella term, Alzheimer's is actually the most common form. And I also want to point out, you can see the top there, that orange 10% AD vascular, as well as in the bottom, that kind of teal color. AD and Lewy body, it's actually common to have a mixed presentation. And so Alzheimer's disease is present in a large portion of the cases of dementia that exist. Okay, a couple myths that I just want to demystify a little bit here. So a lot of folks think dementia means that someone has global impairment. And while that may occur in some individuals, it doesn't have to. There's a lot of cases of dementia that only impact one area of thinking, like memory, but the person may do really well with attention, or maybe it impacts language skills, but other areas of cognition are fine. Dementia is an inevitable part of aging. That's a myth as well. We can go our whole lives and live old age without cognitive impairment and dementia. So it's not an inevitable part. As you know already, it's not always Alzheimer's disease. There's other diseases that can cause dementia. So that's a myth as well. Dementia cannot have an acute onset. That's a bit of a myth. By and large, dementia is a very slow onset that kind of snowballs and builds over time, usually over the course of a few years. But in certain circumstances, it can be faster. And we won't get into rapid dementias in this presentation, but that can occur as well. Dementia is necessarily progressive. There are progressive illnesses related to dementia, but we have to fight against that and do what we can to either keep it static or have some improvement, which is what I'll be getting into next. And along with that last bullet, the idea that it's not treatable, that's a myth as well. So whether you're in healthcare or a caregiver of someone who is thinking about these topics, I hope that you know that there's always something that we can be thinking about and doing to try to ameliorate symptoms and affect change in a positive way. Okay. And then in terms of kind of the next step here, talking about some treatable and reversible things, This is not an exhaustive list, but when we think about dementia, some things may in fact be treatable or reversible. The thing that I do a lot with my research is I study the risk of dementia in the context of infectious diseases, like shingles and pneumococcal disease and even influenza, things of that nature. And we know that those kinds of infections are either preventable or treatable. And so we can lower the risk of dementia with those kinds of approaches. Hydrocephalus is kind of the textbook example of a reversible dementia. It's not always a perfect reversible dementia, but it can be it can be treated quite well, especially if it's caught early. And then there's others that are progressive. So that bottom list there, things like frontal temporal dementia, Alzheimer's, those are progressive illnesses. So they we can still intervene and try to slow down progression, but those conditions do tend to worsen with time. Okay, so the goal here then is to prevent. So we want to be able to prevent it in the first place. We also want to recognize that if cognitive decline has occurred, we want to be thorough and do our due diligence to identify whether a person has any treatable or potentially reversible things so as to not expedite or increase the progression of the condition. And I'm going to give you an analogy of the way I think about that here in a moment. So even if someone has an underlying genetic predisposition or they have already been diagnosed with a neurodegenerative disease, we want to do everything we can to still intervene so as to slow it down. Okay, we can still influence cognitive health before an illness, and even if the illness has already begun, we can still have a positive impact. So I want everyone to kind of walk through a thought experiment with me just for a second. So this is why prevention matters. So I want you to imagine for this thought experiment that we have two patients. We have patient A and patient B. And for the sake of argument, I want you to imagine that both of these individuals have Alzheimer's disease, and in all other ways related to their health, they're identical. So the exact same age, same educational background, same health. Just imagine that they're identical, carbon copy of each other. But so they both have Alzheimer's disease. So patient A there on the left and patient B on the right. And the argument that I would make today is if you walk through this thought experiment with me and imagine that these two individuals are identical otherwise, and they both have dementia, but patient B, in addition to Alzheimer's disease, has elevated blood pressure, depression, insomnia, and a sedentary lifestyle. The argument that I would make is patient B is going to decline faster. Okay? So this is where early identification of risk factors is critical because these kinds of things on the right, hypertension, depression, sleep disorder, and sedentary lifestyle, also increase the risk. So even if this person didn't have Alzheimer's disease, but they had these other things, their risk is actually elevated of having vascular disease, stroke, and dementia over time. So that's why we're thinking about this. Okay. So I always tell my patients, don't speed up the train. Okay. So if we say, okay, early on we have normal cognitive aging, so in 65 they look really good, no memory issues. The testing that we do looks really nice, and then they come back in a few years later, or maybe at age 70, and they're starting to have some cognitive difficulties. If we think, okay, this person may be developing Alzheimer's disease or underlying disease that's going to be progressive, if the train is leaving the station, let's not speed it up. So let's not ignore things like sleep apnea or insomnia or chronic pain and medication side effects and things like this. We want to say, okay, even if the train is leaving the station, don't speed it up. Let's intervene and slow it down as much as possible. Okay. So the evidence of modifiable risk factors is not new. Um, Almost a decade ago now, the Lancet Commission, Lancet is a large medical journal, one of the top in the world, if you don't know. They put a large team of researchers together and commissioned them to identify modifiable risk factors for dementia. The first iteration of this paper was 2017, and it identified risk factors, low education, hypertension. You can see the list there, smoking, obesity, etc. And then you can see over time that they updated this paper as more and more research comes out. So they updated it in 2020 and added a couple additional factors, including air pollution, which is a really interesting one to me. Air pollution significantly increases the risk of cerebrovascular disease and stroke and increases the risk of dementia. And then not so August of 24, they came out with the newest iteration of this, the Lancet Commission, and they added a couple other things, including vision loss and some things related to cholesterol. Okay. From the most recent version, they suggested that if you could hypothetically eliminate all 14 risk factors out of a population. So if we have a global population, if we could accurately identify and remove the 14 risk factors, we would lower the incidence of dementia by 45%. And additional research would suggest that that is possibly higher, more like 55% of cases of dementia. So these modifiable risk factors are pretty important. You may be asking, what are they? So this is the paper. If you haven't read it, if you're a healthcare provider, I highly recommend getting this paper and including it as part of your reading. And also if you're training residents or fellows or anything like that, they should be aware of this paper. It's kind of a lengthy paper because of how many risk factors they review, but it's a pretty good paper. Okay. So I acknowledge that on a PowerPoint, the figure on the right is probably too small. But if you grab that paper that I just shared with you, you can expand that and look at it. But they break these 14 risk factors into different segments of life: early life, midlife, and late life. And you can see the risk factors are lower education early in life, hearing loss, cholesterol, depression, traumatic brain injury, physical inactivity or being sedentary, diabetes, smoking, hypertension, which is your blood pressure, obesity, excessive alcohol intake, and then late life is social isolation, air pollution, and vision loss. Now, the paper, this Lancet Commission reviewed these 14, and they do acknowledge in that paper that there are multiple other risk factors, but they didn't include them yet because they're waiting for a little bit more evidence. But it should also include the ones that I've included on the left. My research, as well as just the field that's looking at these risk factors, is expanding so quickly that I'm confident that the 14 factors over time is going to increase in number. But the ones on the left, so sleep disorders, we know that sleep apnea and other things like hypersomnia and insomnia negatively impact cognition. Chronic pain has an impact on executive function and attention and processing speed. Anticholinergic cognitive burden, which is a fancy way of saying certain classes of medication can have a negative impact on thinking skills as well. My line of research recently is focused on infectious disease and how a broad range of infectious disease causes an inflammatory cascade and negatively impacts the central nervous system. Postoperative cognitive decline even has an impact on risk. And then a broad range of pulmonary diseases as well. So there's a lot of modifiable and treatable things that we can address with our patients. Okay, this looks a little overwhelming, but I promise I'm going to walk you through this. So just focusing on the top blue box, you can see these are a lot of things that impact vascular health, so heart health, so diabetes, cholesterol, hypertension, smoking, obesity, and air pollution and head injury. If you see that top blue box, those things will increase risk of vascular damage, that top red box, as well as have an impact on the accumulation of pathology in the brain and stress and inflammation. And so all those things in that top box do contribute to dementia. So if we treat them, we actually prevent or delay dementia. And then you can see some lifestyle things in the middle blue box. Depression, we can treat depression, we can be more physically active, we can reduce alcohol intake. And that middle blue box is going to actually affect all the red boxes. and then reduce or delay dementia. And then you can see the other ones on the bottom. So I won't belabor it, but all of these things, these 14 risk factors, if we can address them, and we should, then that actually is what's going to reduce risk of dementia over time. This is also from the paper, and I just want to point out that this is how they get to 45%. So they take each one of these 14 risk factors and they basically weigh how big of an impact it has on the risk of dementia. And then they can calculate, well, if we were to eliminate these things, hypothetically, what would that do to reducing the number of cases of dementia? So it's a substantial reduction, 45% reduction in dementia if we could treat these conditions. Okay. All right. So again, my area of research, I do a lot of work focusing on how medical conditions negatively impact the brain. And so last year, Dr. Schaefer, who edited the book with me, she and I put a paper together just to try to spread the word a little bit more about things that you can capture pretty quickly in some screening with patients to identify things that place them at greater risk of cognitive decline. And you can see they're kind of categorized into top left neuropsychiatric and neuropsychiatric conditions. Bottom left is metabolic and endocrine kinds of conditions. We can think about infection and autoimmune conditions, substance-related conditions like medication side effects or alcohol, and then other medical conditions like persistent pain, chronic pain, and heart disease. We do know that hearing loss and vision loss are independent risk factors for cognitive decline. And so we do want to make sure that we're treating hearing loss and vision loss as much as possible as well. Okay. So let's simplify this. So from the Livingston Lancet Commission that I showed you, as well as just a lot of follow-up literature on risk factors, it's pretty overwhelming to kind of go through a checklist that long. So this is how I would simplify it if I was a patient. I would ask the patient, okay, has your primary care doctor evaluated lab tests, which is pretty routine if you're having normal checkups with your primary care doctor. They're going to make sure that you're doing everything you can for your heart health. Your vitamin levels are where they're supposed to be. They're going to look at your thyroid levels. They're going to rule out infections by looking at things like white blood cell counts, etc. Have you had a conversation with your doctor about medications you're taking to make sure that you're using them right and that you're avoiding medications that can have a negative impact on cognition? Caveat here, of course, is anyone listening to this today, I don't want you to change your medications. Please have a conversation with your doctor. Don't just change your medications. Are you abstaining from alcohol? Are you abstaining from excessive alcohol and other harmful drugs? Are you effectively treating any kind of sleep disorder? Do you need a sleep assessment? That's a really important question. Are you treating hearing loss and vision loss? Okay, if you're not, you should be. Do you have depression? Are you receiving the appropriate care for depression? From the Livingston paper, late life depression is actually the risk factor among the 14 that carried the greatest weight in terms of risk of dementia over time. So if you have some depression symptoms, it's normal to have a conversation with your physician about how to best approach that. And then, do you have persistent or chronic pain? Have a conversation with your doctor about things like physical therapy and other treatment options that can help you reduce that. Okay. Also, let's say someone is either cognitively healthy or they are at risk of cognitive change. When we're thinking about prevention, another easy way to simplify this is to put it in what's called the 4 pillars of dementia prevention. And so the 4 pillars of dementia prevention, the most important pillar, if you were only going to do one of them, is exercise. Of course, having a responsible conversation with your primary care doctor to make sure you're healthy enough to exercise, but doing that is probably the single most important thing you can do to reduce your risk over time. Diet, we have probably 25, 30 years of data now that shows things like the Mediterranean diet, the DASH diet, or a combination of them called the MIND diet do substantially lower the risk of dementia over time. We have pretty impressive, robust data now, especially out of Europe, where they have socialized medicine and they have sample sizes in tens of thousands of people to see this effect. And so we know that it lowers the risk of dementia if you're having a diet that's consistent with the MIND diet. Okay. So exercise, diet, social engagement, and cognitive stimulation. These are critical. And so there's some clinical trials coming out now where they're finding that if you engaged in some cognitive stimulation trials, like speed of information processing training, which is to train you to have good reaction time and good processing speed, the long-term benefits of that those actually stick around for a long time and lower the risk of cognitive change over time. So we know we got to keep our brain active in order to keep it sharp, and we need to be social as well to keep our brain sharp. And then sleep health. So treating things like insomnia and sleep apnea, those are pretty critical. So every day when we're going about our business and we have a lot of cognitive activity and things going on in our brain is using energy and it's actually producing metabolic waste, which is normal, but it actually most effectively clears the metabolic waste of the day while you're asleep. And so if you shortchange your sleep, then your brain is less effective in clearing the metabolic waste. Okay, so it's actually um, neurologically important and critical to have adequate sleep. Okay, so get treatment for insomnia and apnea or other things if you need it. Couple of things that have come out the last decade. There's a trial, a large clinical trial called the FINGER trial. This is an acronym, stands for the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability, which is a mouthful. But this is actually a pretty interesting clinical trial. So they took about 1,200 adults that were 60 years old or older, and they identified individuals who were already at an elevated risk of dementia, but who were cognitively healthy at baseline. And they did what they called a multi-domain intervention. So they incorporated diet, exercise, cognitive training, and then monitoring for metabolic and vascular health, so blood pressure or diabetes, things like that. And then they did that for 24 months. They compared it to a control group that control group just received health advice. Okay, so again, they wanted to see if you had this sort of multi-domain diet, exercise, cognitive stimulation, and vascular health monitoring, what does that do? And so they measured cognitive function through a variety of tests of memory and attention and reasoning and problem solving and things like that. And then after 24 months, they reevaluated and they found that the treatment group um, uh, cognitive function was actually 25% better in the treatment group. I don't think I finished my sentence appropriately there, but is 25% higher in the treatment group. And that treatment group was less likely to develop new chronic diseases like blood pressure issues or diabetes. That trial's now a few years old, and so they've also done a lot of follow-up. So around 7 years out of that trial, the treatment group was 16 to 29% less likely to develop stroke and other cardiovascular diseases. So the likelihood of developing stroke was 20%, specifically 20% lower if you engaged in the treatment. So that's pretty impactful if you think about engaging in that and lowering your risk and having better cognition. Okay. And then kind of a follow-up study, and I'm about done here and happy to take questions in a moment. The US Pointer study is receiving a lot of attention now because the clinical trial is essentially done, and I'm sure more papers will come out, but there's been some nice reports already. If you know the journal Neurology, that journal has a podcast, and they had a nice episode recently where they had the principal investigator talk about the results of that. So if you know that podcast, I encourage you to listen to that. But this U.S. Pointer study is attempting to replicate what was done with the finger study. And they had similar group of people, but again, they were at risk of dementia and they had multi-domain intervention. So exercise, diet, cognitive and social stimulation, vascular risk management, etc. But then they divided the group into two things. One was a structured group. So this group was very rigid. They monitored them closely. They gave them coaching and pretty frequent check-ins and accountability to make sure that the group was truly sticking to the intervention. And then they had a kind of hands-off approach with a self-guided group who they were given this important information, but didn't really check in that much, less intense in that regard. Again, they were measuring cognition over time, and in the 2-year follow-up, they found that, in fact, both groups improved in cognition, which is great, and lowered the risk of dementia, but it was the structured group who had the greatest impact. So what that means is if you have these lifestyle interventions and really stick with them and take them seriously, it reduces your risk of cognitive impairment. In fact, improves cognitive function in many ways and lowers that risk of dementia over time. Okay. So again, for the finger trial, the US pointer trial, these were individuals who were already at risk of dementia, and there's clear evidence that these things lower the risk over time. Okay, so this is sort of a summary of everything we talked about. Get exercise, be social, stay active, don't smoke. Okay. Get regular checkups with your primary care doctor so you're being vigilant about blood pressure or get your hearing checked. Get enough quality sleep, and get a sleep study if you need one. Prevent falls and head injuries, and utilize cognitive strategies. Prevention is the most important thing here. Okay, and I think that's probably it. This is just another summary slide, and I'm probably out of time, so I'll pause here. This is my last slide. I'm happy to just have a conversation, answer questions, and if folks have um, questions offline, I'm happy to chat or correspond through email. You can use either my UI, University of Idaho email, or my personal Gmail account. So, okay. Should I stop sharing or?
That was